Good. Thank you guys for coming out. Today is going to be part 2 or 2.0. On 1.0, we talked a little bit about some of the risk factors that come with lung cancer and some of the disparities that are associated with them. And on that talk, we can next slide. Oh, slide. Got it. Okay. I want to give and on that talk, we're kind of talking about some of those disparities, next slide, that focus on the health and we're talking about health in general and the relationship between the health and the health care that you receive. We talked a little bit about the environmental and biology standpoints. Next slide. But what I want to talk about today, we're going to move towards health care and how that impacts and how some people are disadvantaged by that. And when I talk about healthcare, we're talking about the ability to be detected early, to find it early, and move through the healthcare system that allows you to get towards treatment faster and make the improvements. Next. Okay. So just a brief recap. When we talk about screening, our primary goal is to find cancer before it has started causing problems. And we talked about in 1.0 some of those risk factors that would qualify somebody to get screened. Specifically, we're looking at the age, right? Because if you have an age between 50 and 80, that would be one of the qualifications. And then we look at how much somebody has smoked through their lifetime, okay? And that, what we mean by that is we talk about pack years. And if you smoke 1 pack a day for 20 years, that's 20 pack years. If you 2 packs a day for 20 years, that's 40 pack years. If somebody has smoked within their life more than 20 pack years, and they're between the age of 80 and 50, then that would be 2 criteria that met. And then the other thing would be if you smoke any time within the past 15 years. So those 3 criteria would qualify somebody to get screened, to try to detect lung cancer early. Next slide. And so when we talk about screening, our primary goal for any type of screening, whether it's breast cancer, colon cancer, prostate cancer, is to try to find it before you actually have disease, right? Or before you have symptoms, because that's the best time to get ahead of it and then gives you the best opportunities for survival. There's a couple of trials that were done, and we know that if we do a CAT scan once a year for screening, it would lower somebody who has those risk factors, their chances of dying by at least 20%, okay, over a chest X-ray. And your chances, if you follow through the screening all the way through, decreases somebody's chances of dying from lung cancer by 25%. And the reason it is that lung cancer develops silently, okay? So if anybody's ever bruised a rib or injured their lung, it hurts, right? Because in the sides of the lung, there's a bunch of nerves coming all the way down through here, right? And then if you have a lung cancer developing, one of these little spots developing one of your airways here, it makes you cough, might cough up blood. That's another late sign. In the middle of the lung, there's no nerve fibers in there. So it gets a head start, and that's why screening is important, because we want to find it before it's made to the edge of the lung or into the ribs, or if it's making you cough and have coughing up blood. So that's one of the primary goals of it. So who should get screened and who gets left behind? So we know, and I just told you that in the study, if you got screened, you had 25% less chance of dying of lung cancer. Now there are some populations that have even bigger benefit from getting a screening. And African Americans, if they get screened, it's a 39% less chance of dying of lung cancer. The problem is only half of people even know that screening is available for lung cancer. Screening in minority communities, if you do screening, we set up screening programs, it closes that disparity. So you don't see the difference in people getting screened late, because what happens when people get screened late is this opportunity to get to the early diagnosis decreases significantly when compared to other races. If we look here at African Americans and we look at white individuals and we look at the chance of catching it early enough to get a diagnosis, you can see that the African American population across the United States is significantly less than others. And what that translates to is that surgical treatment for cure decreases, the lack of getting any treatment at all is worse for African Americans, and the survival is worse. So the goal is get screened, find it early, get treatment early, and then that disparity, that difference in the outcomes actually improves. Next. Okay. So when we talk about screening, because I can say all I want about screening, you have to ask yourself, what exactly is an abnormal screening? So when we get the CAT scan, because that's what it is, one CAT scan, it takes about 20 minutes to get it done. You do it one time a year, they look at it, and they'll get the results within a week from your primary care doctor, and they can give you the results, and you can figure out if there's something to do about it, or we just continue on to the next year. When you get an abnormal screening, what they're looking for is a little spot. That little spot that I showed you on the last slide is an abnormal, what we call a nodule. It's a spot on the lung. That's all it is. We like to use big terms, but we really can keep it simple here. Right? So a nodule is just a small spot that we see on the CT scan. 95% of what we see on the CAT scan that have an abnormal screening, they're benign. Right? We don't have to worry about they're harmless. There's a few of them that can be related to infection, okay, you can have scar tissue, because remember, everything that we breathe goes in and out of the lungs. It might cause some inflation, sometimes it might be there one year, the next year it's not there. Sometimes it may have been there a long time ago, but we just happen to find it at this one time. Then there are times where it actually is something. It could be a lung cancer, it could be something that's primarily from the lung, or it could come from somewhere else, and then again, still maybe scar tissue on those others. As the physicians, we sometimes sort them into different approaches. And you might hear this say, okay, it's a solid, or it might be part of it solid, or it's just hazy on the scan. And so sometimes we might see just a little haziness there. And some of these, we follow them differently, right? So if it's solid, if it's part solid, we're going to be more aggressive on that, because that means something is grown and filling in, and it's starting to be attached. If it's kind of a haziness, I don't know if it's inflation, I don't know if you had a cough or bronchitis and it went away, and sometimes we just might watch this 1, 2, 3 years and just see if it's doing anything or making any change. But that's kind of the difference in how we think about it and what we're talking about. So it's important for you to know this, because what we found, and this is a study we looked at a population, because I can tell you in our clinic, I'm in Atlanta, and I diagnose about 180 lung cancers a year. It's the 4th largest community hospital, so the community is very similar to what we have here, okay? And we looked at some of these biological and the social determinants about lung cancer disparity. And the biggest factors that we found that really holds people back from being able to get from diagnosis to cure is health literacy, right? Understanding what's going on, what the physicians are talking about, what the providers are trying to work you through, and being able to translate so it creates action amongst ourselves, right? And what we found is a lower health literacy, not understanding what's going on, despite all of the other things that we found, income, access to care, police systems, insurance levels. All those didn't matter as much as how much the person understands. And it's not always education level, right? Because there's a difference between health literacy and education level, right? Because if I go into the mechanic and they start telling us, I know they're working on the car, I understand, I don't know exactly what they're doing, how do they translate that to me so I can understand? And that's what we as providers need to do. And if people that are coming to see us don't understand, that's where we need to find ways to help them understand. Because when we can fix that, it makes a difference. And so now programs are starting, and we should be providing plain language understanding, right? And then we're going to help with navigators to help get through some of this process. Next. So how do we figure out, was that nodule, was that spot, is it truly a cancer, or should we not be worrying about it? Next. So one of the ways that we do this is when we see an abnormal finding, we try to get them to work with one of the navigators. Okay? So patient navigators, these are trained docs. Sometimes they're nurse practitioners. They're just people that are specially trained in doing some of these. And they help with everything that patients are having trouble with getting done. It could be scheduling and transportation. It could be explaining results. And you're going to hear a little bit more about this, so I'm not going to dive deep on this. The other component is, and it's a very, very crucial role, is getting through the system, connecting you with the right resources, but not just connecting you with, but getting it done in a timely fashion to where it can make differences. And the biggest impact it has is in the low income and those home and people are housing insecurity or income insecurity, because if you add a navigator to this, they're about 4 times, almost 5 times more likely to get through this process, get through screening, to diagnosis, to treatment, than if they don't have it. These navigators, the programs with navigators, it's been shown that they actually increase the success rate of patients getting what they need by about 25%. When we think about that, that's 1 in 4 people that weren't able to get where they needed to get are able to get there. That's a huge amount. Next. Okay. So when you have an abnormal finding, that we're looking at this and we explain to you, yeah, we really need to do something about this. The next thing we got to do is you've got to get tissue. Okay. Click. Okay. There's 2 ways of doing this. Sometimes we can use a little camera scope and we can go into the lungs. And there's whole new ways, robotics and virtual, stuff like that. So it's very low, not very invasive, right? And we can get a sample. Or the other way is sometimes they might go under a CT scan and guide a needle, small needle, and get right into it and pull some cells out and take a look at it. It's crucial to confirm because we need to one, confirm whether or not it was an infection or a cancer, and then we get to other ideas, what type of cancer was it? And a lot of times when we talk about this, even behind the scenes, you don't see, we have these big boards and we'll pull up CT scans that have abnormal findings, and I'll sit with a surgeon and a radiation doctor and myself, and we'll all kind of go and say, okay, what's going to be the best step of this? All this goes behind the scenes so this can happen in a timely fashion. Next click. Right. So in those events where we actually do find out that this is a cancer, right? It's nothing that anybody wants to hear. It's not stuff that we like to go tell people. But the reality is once we find the cancer, our time clock starts ticking. And we need to move through the system, move through the process quickly to find out the staging and then the next steps in the treatment. Click. Okay. So everybody hears this, right? And everybody kind of hears staging. What stage am I, doc? Right? Or we'll say, or we'll come in and say, oh, your stage, 2B or 3B. What does that mean? Okay. The very simple thing it means is how big is it and has it spread and where has it spread to? That's it. We go through all the stages, 1, 2, 3, 4. It can be very different, and they have all these A, Bs now. And sometimes we just make things too complicated. So I'll simplify it to you and have these discussions, because the other way to look at it is, if we look at this, is it localized? Okay, so is it in one area of the lung? Okay, or is it regional? So is it in one area of the lung and maybe some of the lymph nodes? Or 2, is it distant and has it spread to other places? Because that also helps us understand what the likelihood of survival is under those conditions. But when we know that when we can catch cancer in the early stage, this early stage of localized disease, that about 65% of the people are still have a good survival. They're still alive in 5 years. Okay? If we catch it at the late stage, about 9%. Now, does this mean that if the doctor comes in and says, oh, you have late stage cancer, and he says 9%, he says, okay, I'm done. Why do anything about it? No, it doesn't mean that. What that means is that's just what the likelihood. You don't know if you're one of the 9% or if you're one of the 91% that aren't. So you still go through treatment. But what this is telling us is that we need to focus on finding it early. We need to get the screening done and then get through the system to get the treatment done in timely fashion. Sometimes I tell the patient, hey, look, we found lung cancer, whatever. Say, oh, I'm gonna get a second opinion. The first second opinion they get is on Dr. Google. Don't do Dr. Google, right? And then they decide, oh, well, okay, now I'm gonna go to another doctor, and so you gotta wait another week to get the appointment, and you gotta get all your records transferred over. Then they're gonna want a repeat test, and by that time you're a month or 2 months out. At that point in time, it's just wasted time. Once we get the diagnosis, we're on a time clock to get you through treatment and get you done. And the concern about this is when we saw lower rates of the screening, lower rates of the early detection, then most minorities and Underserved communities, they're more likely to be diagnosed at later stages, and this becomes this unequitable, this health disparity problem that we have. But we do know that when we focus on these aspects of it, and we get the diagnosis and the treatment, the differences actually balance out. So we don't have the disparity when we focus on our healthcare program. Next. Okay, so we confirm it's cancer. We're asking ourselves how big is it and how much has spread, and then we need to determine that. We need to answer that question. One of the things you'll hear about is a PET scan, okay? And so a PET scan uses a sugar-based diet, it helps light up things. So if we look here you have a cancer, and on the PET scan it helps it light up. In simple terms, they give an equivalent of a sugar molecule. On every molecule of that sugar, it has a little marker on it, a little tracer. And the thought process is, well, the cancer is very active, it's going to eat up sugar, and then they scan and they look for where that tracer is, and this is where the tracer is. If it lights up bright, there's activity going there. Still doesn't mean it's cancer, because infection and inflammation can still be eating up a lot of the sugar, but it tells you that's a target that we need to pay attention to. And what we do is we can look through the whole body, hit the next slide, and we can see, is it in one spot here, or is it in some of the lymph nodes and then different areas of the body, and that helps us figure out what stage you're going to be in. The issue with that is a lot of times PET scans are not available to every hospital system that's there, and so we have to look at where somebody lives. It's not specifically whether or not people can afford it or not afford it. It's does the healthcare system have what you need, and if they don't have it, we need to probably look to go somewhere where it does. And insurance, it factors in a little bit. But we do even know that sometimes the rural areas and Medicaid and Medicare slow things down in terms of getting that. But remember, and what you advocate, if you know somebody that's going through this, or if you yourself are going through it, your hospital doesn't have what it needed, find somewhere that does have what's needed, and now you know what to ask for. Next. Cancer treatment options, just keep it in general. For the most part, if we can find it early enough, we need to get it out of the body, right? Lung cancer is very hard to treat. If you can find it where it can come out, let's have the surgeon take it out. And a lot of times people say, oh no, don't want anybody cutting on me and doing whatever else. This is the best way. About 95% of people that have a stage 1, an early stage lung cancer, and they get it out of the body, it's about 95% of them are still alive in 5 years. So that's number one. If it's not at that point, then there's chemotherapy or radiation or a combination thereof. Okay? But now there's even newer treatments, new targeted therapies, okay? Immunotherapy, and I'll talk a little bit about those in a little bit. I don't even have to, especially some of the women here. You know, men are the hardest ones to go through and get the treatment that they need, even though we know that, oh, come on, I'm standing right here. I'm standing right here. Yes, it is. And so, this is a study, it looked at all of the, of both black men, white women, black women, and they looked at who's more likely to get the treatment that could cure them. Everybody's in the 90s, except black men don't. Well, I heard from y'all already. Like that. But what does this tell us all? All of us in here that tells you this is the population we need to focus on. You know somebody, we need to get them the treatment. So new treatments, and you'll hear this a lot, and if you're not hearing this, you know somebody going through this, you want to ask them about biomarker testing. Biomarker testing. And what we're doing with biomarker testing is we can actually take a little bit of that tissue that we got through either the bronchoscope or through the needle. They look at that and they test the tissue or markers in the blood that the cancer secretes, and they find out what are the weak points. What are the weak points of this cancer that they can attack, okay? They can do the blood, urine, the actual tissue, and there are a lot of different markers. You heard on one of the videos, the KRAS and the ALK and whatever else. All of these are important. You don't have to memorize them, but all these are important things that they're asking to see what's the weak point, next slide, of this cancer. Because if we can find where the genetic weak points are, we can target them. And specifically for cancer, they have its own few things. Some of the DNA mutations in that cancer allow the tissue to grow and thrive. Some of it allows it to build its own blood supply, and if you can cut off its blood supply, it'll help your body kill it off easier. And other parts of it will help it spread. And the reason that's important because in the past few years we have about 38, 39 new treatments that either help your own system fight it off or that we can target the weak points of there. And they're not as caustic. It's not as harsh on the body as it is with chemotherapy or radiation therapy. So people may take a pill once a month, once a week. They may get a shot. But it actually gives better survival. It's almost a 26 to 40% better survival, right? The problem is that a lot of underserved communities, and African Americans specifically, they're not even getting the biomarker testing that's needed to tell you what new treatments, which of the new treatments out there will work better for them with less side effects. So this is another thing we need to ask. If someone's diagnosed with lung cancer, we need to ask them, are they getting the testing on it, the biomarker testing? Next slide. So other ways that we can improve our chances of surviving from lung cancer, because we can do all the medical stuff that we need to do, okay? But there's other things that people can do at home. And they say, well, what should I do? Should I eat something? Should I not eat something? Whatever else. I can tell you one of the biggest things that makes a difference, because we know the number one cause of most lung cancers is smoking. If you have lung cancer, and you stop smoking, your chances of survival go up by 26%. It ain't easy, right? It ain't easy. But if you can do that, it goes up. And early stage, if you have early stage, goes up to 36%. Okay? So because it's not only does it's the effect of smoking and the impact it has on your body and immune system to help fight, it's also the fact that some of the products inside this tobacco smoke are making the drugs less effective. So you'll hear a lot of this, and I have to dispel this myth because I don't like it. People say, okay, well, I'll stop smoking, I'll switch to vaping, okay? It does not do any good with respect to stopping smoking or decreasing the risk of having cancer. In fact, if you switch from smoking to vaping, you have a 56% higher rate of developing a lung cancer. And it's twice the risk than if you just quit smoking alone. So the myth that, oh, I'm going to use this to help me quit is not actually helping you quit. And then when people use these e-cigarettes, the vape pens, they're less likely to quit using any tobacco smoke. And because all of these contain the same chemicals to aerosolize it, the same cancer-causing chemicals that will promote growth of new tumors. So that's myth. You can't do it. Vaping doesn't help you quit. It's working on a cessation program that will get you to quit. The other thing that really impacts how well people do with this that we need to focus on is the stigma, right? This is a hidden barrier, especially for African Americans. And what the stigma about lung cancer and smoking is this, it's sort of a blame game. It's your fault. You put yourself in that position. No, it's not your fault. It's not that. But we have to realize that tobacco use, smoking, it's an addiction. And we have to recognize that. The companies knew that. They marketed it that way, right? They knew what they were doing. But when we start focusing on it like that, it creates shame, it creates guilt, self-blaming. What people do, they say, well, I really don't want to go get screened because people are going to look at me bad because I put myself in this position. Or they're going to not, if they get the diagnosis, they really don't want to discuss the diagnosis. And when we look at some of these scores to see what people feel about with respect to the stigma, African Americans have a higher score. It's almost 10 points higher because of this stigma. And what happens that because they have this fear, that black smokers have this fear of this stigma, and they don't want to discuss it. You know, what do they do? Well, I'm going to smoke, but what do? They go behind the building. They go outside and smoke by themselves, and then they isolate themselves. And it's just a process that goes on and on. And they have this fear of being judged. And you know what? Next slide. The tobacco companies took advantage of that, right? Because what they did is they tried to make you feel good. We go through all the years and different of seeing this. It's like, this is what they do. This has been targeted. For every one advertisement that had somebody that was not African American in it, there were 10 others that had African Americans in it. So they targeted knowing that aspect of it. Next slide. Okay, and they're even doing it now with vaping. This is a whole marketing campaign, a manual for how to target smoking or vaping within African Americans. And you'll see that the advertisements that they use are reflecting this. Okay, next slide. So, what's on the horizon? Why should we be hopeful? Okay. Because we know that when we implement some of these programs, some of these changes in our healthcare system, that we actually can improve the survival for advanced cancers, those late stage cancers. Back in 2000, less than 10% survival percentage. But now, we're up to over 21% for the late stages. Okay? Because some of these targeted therapies, they've been big game changers, right? The biomarker testing, targeted therapies focus on, and we see that some people, we've been treating 8, 9 years, their cancer has disappeared. They came in with late stage, so it's making improvements. And then we have these equitable programs where we're using navigators. We're using our system to pull people through these programs, expanding the screening, biomarker testing, navigators, and then going out, like Amgen's doing today, coming out into the community and educating the community so they know how to move forward through this. Because health literacy decreases healthcare disparities. So, in closing, these are the factors that we can actually focus on and play a role in with respect to the healthcare, early detection, not only the healthcare system, but us through the education that we get and to go out and spread this word and move it forward to move people through the system. Take home points. When we follow these guidelines, when we have guidelines that focus on equal treatment, equal diagnosis, that a lot of these disparities and the survivals, which is what we're going for, actually become equal, right? So we can balance those out. And we know this because there are programs at 5 major cancer centers around, and they found that if we do patient tracking, if we get navigators through, that a lot of the disparities that we've seen in the past decrease and go away. Next slide. And with that, thank you. Yeah.
Thank you very much, Dr. Fulano. I know some of you will have questions. Again, I would encourage you to write them down. We've had some questions come into us online, and we'll get to those